question. C3G, that is true. It's a rare disease. The incidence rate of C3G is about 0.2 to 2 cases per million people annually. So we are talking about an ultra rare disease. A patient who's being diagnosed with C3G, most of the times they've never heard of this term. They come to the clinic, they have no idea what they're dealing with, and they don't know anyone dealing with C3G at the time as well. So that is causing a lot of anxiety. Most of the times, our patients they have a lot of questions about what's happening to me, what's happening to my kidneys. Am I going to deal with dialysis soon? What is this disease and how did it happen to me? Because I've never heard of that before. And when you compare that to other diseases such as diabetes or high blood pressure, it's so different. When patients come in with high blood pressure, most of the times with hypertension, most of the times patients they know of someone who's been dealing with high blood pressure. So it's not something that they haven't heard of the name. It's not something that they feel like this is anxiety provoking. They know that there are medications out there that they can take. And hopefully, if they go with changes of in their lifestyle, if they exercise, if they lose weight, if they take their medications, they should be fine. With C3G, there are so many unknowns for the patients and also physicians at this point that causes a lot of anxiety. For years and years, as a rare disease, for C3G, we didn't have any FDA approved medications for treatment of C3G. So imagine getting diagnosed with an ultra rare disease that you've never heard of the name, not knowing if there are any actually medications out there that can help you to preserve your kidney function. Coming in, most of the times, our patients have a lot of symptoms at the time and not knowing that if there is any medication out there that can actually alleviate your symptoms. So I think the rarity of the disease is something that is affecting on both sides. A lot of physicians might not be comfortable treating C3G because they've never seen a patient before and they don't feel comfortable starting treatment for these patients. So that causes a lot of referrals, many appointments for the patients. And by the time that they're seeing an expert in C3G, they've seen so many doctors, they've heard so many different opinions, and they even sometimes like they feel like really disappointed and they feel like they have to give up because they haven't found a medication that works for them. The future is really unknown to them. And a lot of my patients, when they come to the clinic, C3G has affected their lives in many ways. And they feel like the future is going to be affected by the disease that they've been diagnosed as well. This is a really good question, and I know that there are some controversies about how you define C3G. We just published a paper on kidney medicine recently, and I had the honor of collaborating with many experts on this paper. We define C3G as a rare and complex pattern of injury, which is something that you see it on the kidney biopsy. Basically, when you do the kidney biopsy for patients that they have protein or blood in the urine, you look at the tissue, and in patients with C3G, you're going to see under IF that C3 is positive. At the same time, you don't see any other positivity on the IF at the same time. And that's the time that you diagnose these patients with C3G. C3G can be divided into two subtypes, dense deposit disease and C3 glomerulonephritis, C3GN. About 50% of patients with C3G, they progress to kidney failure in 10 years. So I think having that concept of having C3G as basically an umbrella, which is you're going to see dense deposit disease and C3 glomerulonephritis as um, disease entities that they go under this big umbrella of C3G. Once you diagnose someone with C3G on the biopsy, we usually do many workups for our patients that include a lot of blood tests. This is a disease that is coming from a dysregulation in a complement system. So we do a lot of testing about complement system. We try to rule out other causes of seeing this kind of pattern of injury on the biopsy, and we try to narrow it down to specific diseases. If the patient gets diagnosed with C3GN or dense deposit disease, then we start talking about the new FDA approved medications that is out there and how to treat them and how we can preserve their kidney function. Understanding of C3G is actually evolving these days. Especially now, we have two newly FDA approved medication for treatment of C3G and dense deposits. Now we are looking into the history of these patients and see that which patients are actually going to do better over time versus patients that they probably going to progress to end stage kidney disease or needing a transplant. Um, a lot of factors goes into that. The clinical presentation, how sick the patient is at the time that they're presenting with the disease, how much protein they have in their urine, what's their reserved kidney function at the time, what are the exact findings that we see on the biopsy, how much fibrotic tissue do you see at the time, how active the disease is at the time that you're diagnosing them, and how they're going to respond to the treatment. These are all the factors that comes to mind when you are thinking about the overall prognosis of these patients. This is a really hard question to answer, and of course, 100% of my patients, they ask if you think that I'm going to need dialysis at some point, or if you think that I'm going to need transplant at some point. And it's really hard to say yes and no to these patients. Again, there are so many factors that are affecting their prognosis, overall prognosis. And this is something that evolves over time as well. Now, with the newly FDA approved medications, we are hoping that this kind of progression of the disease is going to change in the future, because for years and years we were doing off-label medications for these patients. We didn't have any specific medications to treat C3G. So this is something new, and hopefully the prognosis is going to be better in the future. But of course, we're going to need prospective studies on these patients and see how they do with effective treatment over time.